Welcome to Bridging the Gap, centering interdisciplinary care in holistic health models, an hour-long webinar featuring Professor Rhonda Marriott AM, Professor Dawn Bessarab, and Professor Ros Walker, hosted by me, Michael Mitchell. Firstly, we'll do an acknowledgement of country, and we acknowledge that we are situated on Noongar land, that Noongar people remain the spiritual and cultural custodians of this land and continue to practice their values, languages, beliefs and knowledge. We recognise that people are joining us remotely from many different lands across Australia, and we therefore pay our respects to the cultural custodians of these lands. We also acknowledge our allies and supporters who walk with us towards social justice. Last year, we saw the 10th anniversary of the second edition of the landmark textbook, Working Together, Aboriginal and Torres Strait Islander Mental Health and Wellbeing Principles and Practice, which is the purple cover here on the front, as you can see on the screen. It's a book that was central in decolonising the discourse in Aboriginal and Torres Strait Island mental health and wellbeing, and continues to inform policy and practice across many sectors today. Here at Transforming Indigenous Mental Health and Wellbeing, we've been celebrating this anniversary and hosting webinars covering topics from the book. Today, we're very lucky to have three of the co-authors of the Working Together book. We're doubly lucky with Ros also being one of the co-editors, coming together for a discussion on interdisciplinary care. These three authors all worked on chapter 13 of the book, Interdisciplinary Care to Enhance Mental Health and Social and Emotional Wellbeing. I would like to take a moment to acknowledge the other authors of the Interdisciplinary Care chapter, Dr. Clinton Schultz, Professor Faye McMillan, and Dr. Jane McLeod. A couple of quick housekeeping points. This event is being recorded, and we will share the recording and the PowerPoint slides later with everyone who registered. Cameras and audio for all attendees are automatically turned off. There will be an opportunity for questions to be answered by the panel at the end of the webinar, and we would love to hear from you out there. Feel free to type your questions into the Q&A box on your screen from now onwards. We will do our best to answer as many questions as we can. Just keep in mind that we may not get a chance to address them all. And what we will endeavour to do is we will endeavour to answer those queries after, once we go offline. Yeah, now. So, we're very lucky to have three of the authors of the Working Together book here with us today, and I know them all, which is fantastic. They know me, which is good. I'll be introducing each of them shortly, but first I'll introduce myself. I'm Michael Mitchell. I'm a Yamatji man of Nyamal and Mulgana descent. Nyamal on my father's side, the Mitchells in Port Edwin, and Mulgana on my mother's side is the Belottis in Shark Bay, and my country extends from the Pilbara to Shark Bay here in WA. I started my working life as an electrical apprentice. I did pass. I was a qualified electrician, didn't work there. But then I went on to play footy with Richmond and Claremont, and I then came back to Perth, and I was fortunate enough and I guess diligent enough to get a degree under Professor Pat Dudgeon and them at Curtin University, a Bachelor of Applied Science in Aboriginal Health, specialising in mental health. And I've worked in mental health for a long, long time now. Worked at the Specialist Aboriginal Mental Health Service in most recent times, but now I work as a consultant and I do my stuff here at Transforming Indigenous Mental Health and Wellbeing, and Centre for Best Practice, Aboriginal and Torres Strait Islander Suicide Prevention with Pat. So what I will do now is I will introduce Professor Rhonda Marriott. I will introduce Professor Rhonda Marriott AM, is matrilineally descended from the Nyakina people, family connection to Archies, Watsons, Hunters and Archers. Professor Marriott is a nurse and midwife and Pro-Vice-Chancellor at the Euro Institute for Change, Murdoch University. She has extensive senior university leadership and translational research experience. Has had a long...
I think it sounds okay. It is okay.
Is it?
Yes.
Okay. I thought the sound wasn't working, but hopefully it is. So I'll keep going. Otherwise, I'm doing a good job on mine. Now, Rhonda has had a long career practicing as a nurse and a midwife, and a long and extensive career as an academic. As a senior university leader, Rhonda now has the privilege to champion the translation of Aboriginal led, co-designed research, evidence and outcomes for national policy and practice to ensure system change to strengthen the futures of Aboriginal families and their communities. Professor Dawn Bessarab is a proud Yindjibarndi woman with a social work background and is the director of the Centre for Aboriginal Medical and Dental Health at UWA and principal investigator on the Good Spirit, Good Life Centre for Research Excellence in Indigenous Ageing. She is a highly regarded and sought after leader in Indigenous methodologies and participatory action research. Professor Bessarab developed the framework on clinical yarning as an Indigenous conversation which is now widely applied across the Australian and international communities. Professor Ros Walker is Director of the Coolaman Research and Advocacy Centre, Deputy Director at the Nyang Euro Institute for Change, and a Professor and Senior Principal Research Fellow at Murdoch University. She is also a Principal Research Fellow here at Transforming Indigenous Mental Health and Wellbeing. Professor Walker has been involved in research, evaluation and education with Aboriginal communities and Aboriginal controlled organisations for over 35 years. As a senior researcher at the Kids Research Institute, Ros co-led the development of the evaluation framework for the Aboriginal and Torres Strait Islander Suicide Prevention Evaluation Project at ZPAC in partnership with Professor Pat Tudgeon. I'm now going to hand over to Professor Ros Walker, who is going to share a little about her work, her relationship with interdisciplinary care and her involvement with the Working Together. So over to you, Ros, and thank you very much for coming.
Thank you, Michael, and thank you for the introduction. Okay, a little bit about myself. Well, I think Michael said most of it, but what I do want to say is that it has been a great honour and privilege for me for the last 40 years to be working in Aboriginal health, Aboriginal education and areas where the whole focus working alongside Aboriginal people has been on transforming the, bringing about change and transforming the systems that have been so impactful adversely for Aboriginal people since colonisation. So it's been a great honour for me to be able to do that. Having the opportunity to work with Pat and Helen Milroy on the Working Together book was just something phenomenal. And the fact that 10 years on, it is just still being referred to and is still being meaningful to students, to practitioners and policymakers. Again, it's a great honour and privilege that I've been part of that. It was also a great honour to work alongside Dawn and Rhonda in the interdisciplinary care chapter that we worked on. And it was pretty groundbreaking at the time, as was many of the areas of the book that we're still, celebrating today, in that we were really pushing against many of the biomedical science narratives, and also pushing back against and trying to inform in really positive, empowering ways practitioners working in mental health and social emotional wellbeing. So it wasn't just an opportunity to critique some of the things that were happening, but to come up with some very important ways forward. And I think the interdisciplinary care book was precisely that. Chapter, we really spend a lot of time talking about, well, what does it really mean? What is interdisciplinary care? And we came up with a definition ourselves, which I sort of looked at again. And I think it's just important to remind ourselves that it is care offered by a group of health practitioners, paraprofessionals, social and other community service providers, including Aboriginal and Torres Strait Islander community members who work together to provide social and emotional wellbeing care for individuals, family and community. And I think we really took this very holistic approach, and then had to, many times with Clinton and other authors, really work out what that meant. And so the idea that it was sort of underpinned by human rights and a framework of change was very important at that stage. And I think I'll hand over to Dawn, who has something more to say about it.
Thanks, Roz. Hi, everyone. Michael's already said a lot about who I am and where I'm from. And I guess as a researcher working in the area of Aboriginal health research, I've been doing that for the last 30 years. But when I worked with Roz in writing the chapter for this book on interdisciplinary care, and Clinton and the others, I was new to research at that stage, I guess. Not too new, but when we started talking about interdisciplinary care, there wasn't a lot of that really being done. People were sort of talking about it, but not really understanding what that meant and how that was different from multidisciplinary care, because there was a lot of conversations around multidisciplinary approaches. And I guess the difference with, and we talked about this, what was the difference between multi and interdisciplinary care? And the main difference was that when we looked at the definitions of multidisciplinary, it was around, where the doctor heads up the team and is the responsible person for facilitating discussions or conversations around the patient that's under discussion, whereas interdisciplinary doesn't have the doctor. He's part of that team, but he's not necessarily facilitating the discussion. That can be done by anyone on the team who may step up and take responsibility because they might know more about the issues impacting the patient. And then everyone else who's part of that discussion then comes in and provides their own input in terms of what they think from their disciplinary approach the issues might be, or the considerations that do need to be taken place in relation to the patient. One of the things that I was very much aware of back then was that social work really wasn't included that much in those conversations. And I think that that was where I was asked to contribute, because social work has a lot to offer interdisciplinary approaches to working with an Aboriginal patient, because social work does tend to come from a human rights perspective, but also employs a lot of what we call SEWB, and particularly the model that Pat and Graham wrote about in the book in the chapter around social and emotional wellbeing, was that there are many dimensions to a person's health and not necessarily the biomedical dimension. And so that when you're working with a patient, particularly an Aboriginal patient, that's where social work can provide a lot of input, because as a social worker, I used to notice, and I had feedback when I'd be with clinicians, they'd all be talking about the biomedical, the clinical aspect, and then I would come in with an SEWB and they go, you talk very differently. You've provided a very different perspective. And that was when I started to realise that social work does provide a different perspective. And those things are really important because when we talk about health of Aboriginal people, we know we're talking about holistic health, which is more than just the biomedical condition. But we need to take into account the SEWB aspects, which can be around family, country, housing, all of those things. So that was where it was important to talk about the role of social work in interdisciplinary care. And I think the other area which I found interesting was that when I was talking to a pharmacologist and asking, were they involved in interdisciplinary teams, and they said that very rarely are they called to come in and provide a perspective because they have the background in drugs and how drugs work with each other. They're up to date with the latest drugs market. They can talk about how two drugs might work or not work together, but they felt that their input was not really called upon. And when we talk about Aboriginal people, and we know that our mob have lots of comorbidities, and particularly when we talk about mental health, there are lots of prescriptions that are provided. But when you talk to people, and you ask them, do you understand what this drug is for and what it's doing? They don't really understand. And I think that this is where it's really important to have that input. When you've got diabetes, you're sent along to a dietitian who talks to you about food, but very rarely are you sent along to a pharmacologist who can actually say, do you understand what this drug does? Can you understand what happens if you mix it with something else, or if you don't take it, this is what's going to happen to you. Those conversations are left up to the doctor, which is important and it should, but sometimes that other information is not always explained. So I think in writing the chapter, this was really important to talk about the role of the pharmacologist in interdisciplinary care, particularly if we're talking about medications and talking about changing someone's meds and all of that. I'll hand it across to Rhonda because I'm sure Rhonda can also talk from her perspective.
Thank you very much, Dawn, and thank you, Ros, and thank you very much, Michael, for the introductions. As with Ros and Dawn, I feel as if I've been introduced, so I don't really need to introduce myself any further. And I'm hoping that you can all hear me okay, because I'm not sitting, unfortunately, with the other two, having, I think, got some kind of virus, which I'm deciding not to share any further with anyone today, with my dear colleagues, Dawn and Ros in particular, and Michael as well. The role that I play, I would like to play a little bit about my role at Nyunkira, because it has a lot of bearing on my involvement with this particular chapter in interdisciplinary care, and about working together, and about bringing about change, and about having very much an eye on holistic care and what that means for the end user, or the person who is, and I know that we don't like to use this term, but who is the consumer of the care that we're providing, who actually has a very big say in the care that they receive, and should have a lot more say in the care that they receive as well. So I'm really excited and very privileged that I have been involved with incredible Aboriginal and non-Aboriginal allies over the last, 20 odd years, but in particular the last 12 years in working full-time as a researcher, which has been an absolute privilege. To be able to work with like-minded colleagues who have a commitment to the work that we do, a commitment to, in particular for my interest, to mums and fathers and young children And that whole transition in that first 2,000 days of the child's life, and being parents, you know, transitioning sometimes for the very first time to being a parent, but in particular about co-designed research that provides us with the evidence to bring about change in health services, in systems, because our systems aren't always easy to change, and without evidence we know that it's almost impossible to bring about change. And the privilege of being able to be involved in this research, to see meaningful research that's translatable into, and it's practical, into clinical areas where, you know, mothers and fathers, children, grandmothers and grandfathers are intersecting to quite often not to receive care because they're unwell, but to be involved in a joyous event of bringing a baby into the world. And unfortunately into a situation where often those systems think very much that pregnancy is an illness for our mob, that mums are sick, that they're high risk, and not thinking about the positive aspects of bringing this wonderful baby into the world. So the work that we did in writing this chapter has actually formed, when I think about it, a thread through a lot of the work that I've done, Ros and Dawn, over the years. And it's been an incredibly important benchmark to go back to around what our aspirations and our thoughts were at that time. And I suppose a bit of sadness for me in that I know that some things have changed remarkably, so I'm excited about that. But there's still a lot of things that haven't changed, and I think we still have a lot of work to do in being able to change hearts and minds around mindsets that people have. And I hope that the work going forward will, from this chapter, inspire maybe us to rewrite where we're at now and revisit that, but for others to be able to think about the pearls of wisdom that I think are still relevant for today. Having said that, Michael, I'd like to hand back to you now. Thank you.
Thank you very much for that, Rhonda. That was excellent. Just from my perspective, just listening to the three contributions, what we did at the Specialist Aboriginal Mental Health Service was exactly what you all said. And no questions asked. And that's why our service worked and made a difference for countrymen everywhere. The model works. So, no, it's fantastic. And we utilised the book as well. So it was fantastic. Now, so there was some, we've got a couple of initial questions. So we'll do our best to answer as many of the questions as possible. And yeah, but we thank our three speakers for that. That was very informative and very insightful. And at the time, would have been a battle, as it always is, Aboriginal health, mental health, anything to do with Aboriginal. So to Rhonda, we've got the first question. We've had a couple submitted ahead of time and we've got a couple coming in. So please send all your questions in. We'll endeavour to answer them online here. And what we will also do is, if there's some after, we'll endeavour to answer them and get back to you with the queries. So we respect your input in that process. So to Rhonda from Gemma, could you share some insights in the role of midwives and nurses and nursing in interdisciplinary care, please?
Thank you very much for that question, Michael and Gemma.
Yep.
I think that my biggest insight that I've gained is, and I am a midwife and I am a nurse, is the realisation that we talk as midwives a lot about woman-centred care. we don't talk very much about family-centred care, and I think we should. And the focus on women tends to ignore the fact that there's a baby in that process, or that there's a child in that process. Midwives and nurses now have achieved the status which wasn't available then, of being endorsed either as nurses or as midwives, and therefore being much more independent in their roles. And I think that that's a really exciting thing and an exciting process going forward, because it moves the concept of the role of nurses and midwives into a very different area of being much more equal as professionals, which is so important when we're talking about interdisciplinary care, let alone when we're talking about multidisciplinary care. But I think that some of the things that we still really haven't moved along with, while focusing on our own professional role, has been what I talked about a moment ago, and that is we need to focus on the family, and we need to put the family at the centre. And I think we need to shift our focus, particularly as midwives, from an illness model and from a risk averse model, where we think that Aboriginal women are high risk, to a model where we're looking holistically at the family, and we're looking at our families, the mother in particular, you know, she's going into from pregnancy into a birth situation, can be empowered and be very much a part of leading the care that they have. In talking about how we empower families and how we empower women, we need to be much more inclusive in what we're doing. And by being inclusive, not only with other disciplines, but also not forgetting the really important role that Aboriginal health practitioners have in our services now, and Aboriginal health workers. And that many women are coming from having received their care largely through an Aboriginal-led unit, which might be an Aboriginal medical service, or it might be somewhere lovely like Bajari Orbers in Armidale. And that many of those staff are Aboriginal health practitioners or Aboriginal health workers. So to be inclusive of them is really important for us to having our eye on, and how we enable that to happen, because all professionals need to be coming together around the family, and all professionals need to be empowered to be able to do the best that they can do to support these families to be the best that they can be as well. My sense around how we're moving along that trajectory of change, Michael, is that I think that we are on the pathway, but we haven't gotten the car to drive it yet. And I think that's the exciting part that still is yet to come.
That was excellent. The other thing I was thinking is that the awards for all the Aboriginal professionals need to be reasonably aligned to, within reason, to mainstream staff. And understanding that that's where the issues come in around there are lots of things. Where good work lost because someone else is paying more. So that percent may be lost. But that was excellent. So thank you very much for that, Rhonda. To Dawn from Caleb, could you share a little on the role of social work in interdisciplinary care, please?
Yeah, thank you for the question, Caleb and Michael. I think social work has a lot to offer interdisciplinary care, because social workers think broader than just the clinical issue in relation to the patient. And Rhonda's point around we do need to bring into account family-centred approaches not just focus on the patient-centred, because social work looks holistically at it doesn't just see the patient in isolation to the family. So there'll be things that social work will consider in relation to, you know, where is the family support, or does this person have family support? Who are they living with? What's the housing situation like? If we're going to discharge, where are we discharging this patient back into the community? Do they have somewhere to live? Do they live in a regional or a remote area? Because these are the things to think about. So social work takes a holistic approach. They look broader than just the biomedical. And I think that's the role that social work, also social work thinks around, is this around social justice issues for the patient? Or one of the things we do know, and particularly from my work in the research area, is that, you know, racism still plays a very, very big part in terms of how patients are treated or listened to or not listened to. Aboriginal health workers, social workers can come behind and support the voice of Aboriginal health workers or Aboriginal health practitioners to be heard in the space of interdisciplinary care, because Aboriginal health practitioners will often think broader as well than just the biomedical. So social work as a support to Aboriginal health practitioners, as a support and an advocate to work together with Aboriginal people, has a huge role to play. Because we do think of and look outside the box and think about all of the different components of the SEWB model, which does look at country, which does look at family, which does look at spirituality. You know, it's not just about the person's medical health, but it's around their mental health and how is the mental health linked to their spiritual understanding and their spiritual well-being. And that's a conversation that social work, because in social work we're trained to ask questions and we're trained to see patterns. And that's one thing I've noticed about doing social work, is that we're not frightened to ask questions or to engage in a hard conversation, whereas other practitioners, that's not their area of skill or discipline, and so they're a little bit reluctant to ask the hard questions. Whereas social work, we're taught to be able to come in and ask a hard question of a family that they may not have thought about, or they're a little bit reluctant to address, but it needs to be asked and it needs to be answered, because it's going to have a huge impact on the patient's well-being, particularly if they're being discharged back into the community and they don't have the supports, or the family are restricted in terms of their economic resources. Social work looks at all of that. So I think that's the role that social work can bring to interdisciplinary care.
Excellent. Great answer. Yeah. So social work is holistic and always been family-centred. And that's everything countrymen are looking for.
Yeah.
So that's an excellent response. So to Ross from Rama. And folks, keep the questions coming. We've got a fair few questions here, so we'll try and get through them. But so have your thoughts on interdisciplinary care changed much since 2014? If so, how?
Okay. Thanks, Rama and Michael. That's also a very good question. So have my thoughts on interdisciplinary care changed much? On the one hand, I would say interdisciplinary care is as important now as ever, and perhaps even more so. And I think both Dawn and Rhonda, in talking from their discipline perspectives, have touched on some things that are the same for both of them, and that is the issue still of racism that is evident in healthcare settings. And Rhonda said it's still about changing hearts and minds. And I think that thinking about interdisciplinary care, we need to be asking seriously, how can we ensure that this is happening? So with genuine engagement by all of the members of a team, so that doctors and people who see themselves as in perhaps higher disciplines don't ignore or overlook the important role of Aboriginal health workers, Aboriginal caregivers, or all kinds of different roles that Aboriginal people play into the interdisciplinary model in Aboriginal settings. So I think today, as much as always, that it's very important to, part of that bridging the gap in centering interdisciplinary care requires cultural safety. It requires co-design and all of the elements that we are committed to in all of our roles, both in Dawn's work, in work that Rhonda and I do at Nunkira. And so these things, as much now as before, when we were first kind of thinking these things through, perhaps at times quite idealistically, are still now critical. And we need to, when Rhonda said, you know, be good to go back and visit, you know, a publication, it really excites me, because I think there's things that we could do now that could help support how you can operationalise these things more. And something that that we worked on in that chapter of bringing together this bio-psycho-social, cultural, spiritual framework, we were all very excited about at the time. And people left me to get Chrissy Easton, who was working and doing a lot of the diagrams, to try and visualise what this framework might look like. And the importance of culture and spiritual domains was something that we all discussed, all of the authors together. And I think that's something that still to this day is just still equally important and needs to remain emphasised. So I think there's some exciting areas that have changed. So, and I think there's things that we now know that we could add to in a very valuable way to make sure that we're still putting the importance of interdisciplinary care forward.
Can I say something?
Sure.
I mean, Ross, I think it's really important what you've said, because what we're talking about here is interdisciplinary care involves different knowledge systems.
Mm.
And so the different disciplines that are involved bring their knowledges to the table.
Yeah.
And more importantly, when we talk about Aboriginal knowledges, then Aboriginal people don't just bring the clinical expertise that they have, but they bring their Aboriginal knowledges to the table.
Mm.
And I think often that's not heard or listened to, because what focuses on is the clinical. And I think this is where it becomes really important, because we're talking about a holistic approach. We're talking about you need both systems to help the patient or the client to be able to make changes or to address what's going on for them. So I think this is the area where I often hear from Aboriginal health practitioners and Aboriginal health workers who are in a hospital setting, and they can be sitting at the table discussing an Aboriginal patient, and they say, nobody listens to what I say.
Yeah.
And they're all saying that this should happen. And I'm going, yeah, but hang on a minute. You know, or for instance, they're talking about discharging, and it's like, where are you discharging this patient to?
Mm.
Can you discharge them home? Because I know the family. So then they're bringing in their knowledge of the community, of the family, and saying, I don't think this is going to work. But she said, nobody listens. And then what happens? They discharge, and then the patient's back in a couple of weeks with a really bad infection. And had they listened to me before, that wouldn't have happened.
Mm.
So I think what the change that we're still fighting for, and even though there has been change, there's still some pushback and resistance to acknowledge the legitimacy and the validity of Indigenous knowledge systems, which go beyond the clinical, but bring in all of those aspects of culture, of family, of community, of issues, the socio-economic issues, all of those things, the history of soul and generation, all of that into the discussion. And I think that there needs to be a concerted effort by our other disciplines, like the doctors who have got knowledge around medicine, and that's important, that's why they do what they do, to acknowledge that Indigenous knowledge is just as important and holds weight and can really add a lot to the well-being of the patient. So I think that's work that we still have to do, and that's coming up against some of that inherent bias within the system.
Yeah.
where there's pushback, and there's that we're still fighting to have that acknowledgement that Aboriginal knowledges have a place to play and they're very valid.
Yeah, absolutely. And spot on. And and what was interesting is the Aboriginal professional brings to the table the importance of what you brought up about the cultural and spiritual domains.
Yeah.
And many times that's everything. However, if the MDT, the multidisciplinary team, is not aware of it, they go down the wrong path. But
Or
anyway,
they don't
that's
think
just
it's important.
yes, they don't rank it enough.
No.
And the key to the Aboriginal professional is the buy-in. They get the buy-in from the patient and the family.
Mm.
And they understand the dynamics,
Yeah.
which is everything.
Yeah.
So that's excellent. Now, so we got a couple of good questions from the audience. So time goes very quickly, unfortunately, when you're having fun. And we're having fun, and it's been very informative. And this is important too, because we're all getting a little bit older, and we're having a bit of a yarn earlier about talking about retirement and thinking about what's going on. So this is important because the next wave has to come through. And so to all editors, I haven't got a name of the person who sent this question in, but it's excellent. Where do we go from here? Do you have any thoughts of messages or upcoming groups of researchers, writers, academics, or health professionals? Because what they're basically asking is about the future. So we've got some time left. So if you can be as succinct as possible, and we'll get all three of you to weigh in on what you reckon. So that's a great question. Whoever wants to start.
Well, the future. I think, one day it would be nice to be able to sit here and racism is no longer an issue, because our system is equitable and people are being treated according to their needs and not being based on race. People don't feel frightened. Our mob don't feel frightened to access health services because they're going to be treated differently. We no longer have our mob dying in a hospital setting to something that could have been prevented, but because of the lack of proper medical services or attention, someone dies. And I think that to say that, there's still a lot of work to be done in this area. So I think research, we need to move just beyond, we know what the issues are. What we need to find out more about is what stops government, what stops our systems from doing things differently. Systemic racism, systemic bias. Why is it so hard to change the systems? What else is going on behind the scenes that they're not doing that? People say that the Aboriginal, the reason things don't change is because Aboriginal people are a huge industry. And if we start to heal people, that industry will come to a close. Well, is that an urban myth, or is it real? So what is stopping government and the higher systems from making those changes? And I think there's more research to be done in that area, but to not just identify, but to actually start to get down to the brass tacks of what is stopping this from happening. And I think that's the work we need to do going forward.
Agreed.
Yep. Anyone else want to comment on that?
I absolutely agree with what Dawn has said,
Yeah,
and that it's really, really important that we have more understanding about what it is that prevents change from happening. Because when in the kind of research that we're doing, we do see that there's a huge willingness from individuals, there's a huge willingness from services to change. But I think the bureaucracy of change, or the bureaucracy that health services have in place, almost prevents that dialogue, prevents that change from happening, and certainly doesn't foster change. It fosters the status quo because systems are set up to function, and they function best when they're left alone to function. and it's only, it's only when they come across the unusual that they have to, regroup and consider how they deal with this unusual circumstance. And having worked in health systems for a long, long time, I know how difficult it is, and I often liken it to trying to turn the Queen Mary ship around in Fremantle Harbour. It takes a long time, and over my 50 plus years of working in health systems, I can say that things have changed an enormous amount. But probably the biggest change that we have seen has been in the last decade or less. But it's not enough. And I think that, how do we translate what we're seeing in individuals, and we're seeing in some parts of health services, how do we translate that more broadly so that wherever it is that Aboriginal people are intersecting with health services, that they're having a good experience, that experience means that they come back when there are issues, they come back when there's problems that they need assistance with, that they're being empowered in the process. And we're nowhere near that yet.
Yeah, just going back to the question, Michael, was about how people coming through could be part of that. I think when Pat and myself and Helen, the first webinar, Helen said at the end, we need some young researchers and practitioners to get in there and do the next edition, to pick up on the new gaps that are being discovered, and perhaps not just that, but to pick up on these barriers that are still there, and come up and to talk about some of the solutions. And there's many aspects within the book. There's standards, there's practices, there's understandings of context which can provide the basis going forward. But to have people have permission to grab that next baton and take it on, and that might mean one of the universities getting in there and arguing with the Department of Health in Canberra to do what they did with us and provide a basis of money to be able to support different groups and young authors to come through and take up the authority is there, and take it up and take it to that next level of transformation.
I think one of the things that was really important about these books edition is that they didn't just provide a theoretical approach to understanding the issues. They also combined a practical. So they provided the theory, but also what you can do. And I think that's what's really important. We don't just need the theory, but we also need the how-to. And that's why these books have been totally invaluable to such a wide range of people out there in actually knowing, well, this is what the issues are, but they're also saying this is how we can do it.
No, absolutely. And you're spot on there, because when we set up the statewide specialist Aboriginal mental health service, this book, the purple book, it was the blue book. What I think?
Orange.
Orange book.
Mango.
Yeah, I'm a bit colourblind. It was important in that established and it gave all the answers to the naysayers. Yeah, and you kind of answered one of the questions, will there be a third edition? And if so, when? So, Ros, when you said, so put out the thing there to all the young researchers around. So now, we're running out of time, but that's okay, we can still battle on. When you co-authored chapter 13 of the book, Clinton Schultz, Faye McMillan and Jane McLeod, what was the approach to interdisciplinary care like in Australia? You kind of touched on it. but it has changed thanks to the book and your advocacy. So, yeah, if you can comment.
I think there was a lot of multidisciplinary types of approaches, and interdisciplinary was pretty much just, I think, starting to become part of that discourse. And that was the conversations that we had. What do we mean by this?
Yes.
And how is it different, and why is it important, and what is different about it as opposed to multidisciplinary?
No. And there were still the issues of power relations were really strongly working against Aboriginal health workers, mental health workers, the first psychologists coming through, having a very strong and real say into some of the areas, and some of the discussions that Clinton brought in and Faye were around, living examples of things happening with patients going into GPs or to psychologists, and how to get that crossover and conversation going. So I think there was definitely a huge conversation around the multidisciplinary, but in terms of we actually use the notion of interdisciplinary care as a way to really privilege Aboriginal roles in this area. I'm not sure what you think, Rhonda, but certainly had conversations around those power relations.
I agree. I think that the power relations unfortunately still exist, but I think there has been some shifts in some of the professions. And if I use midwifery and nursing again as an example, we now have the opportunity for nurses to become endorsed nurses, nurse practitioners, and for midwives to be endorsed as well. And so that does shift the power relationship with the GPs that the nurses are working with and midwives are working with, because they no longer need a GP to sign off on them writing scripts. So there can be a lot more active engagement with clients that are coming in and seeing them. But I think in hospitals, it's probably we're still fairly traditional in our roles. So, and the system itself maintains, in a way, those roles, those traditional roles. So, while there's a lot of conversation and a lot of discussion, I think that we still have more power imbalance in those systems.
I think sometimes too, you often hear the argument of time. We're running according to the clock. We don't have time for a huge conversation, but I think that that can sometimes also be an excuse, because that gets into the power differentials that you're talking about, Rhonda. And if we're really looking at interdisciplinary care, it's about the quality of the discussion. And if you're bringing people who've got really important information to add to that conversation, that can actually save time at the other end. So I think that there's some challenging around that discourse of time, which is, of course, based around economic, productivity and all of that. And I think that's the system. The market system also drives some of this. And there's if there's changes to be made, it's around, how can we provide evidence to show that if you actually put the time in, you tend to have better outcomes. So I think there's, research around that could be useful going forward.
True.
Yeah. No, excellent. Okay, look, we are very quickly running out of time, so we'll start to wrap it up. Unfortunately, that's what happens when you're having fun. So thank you for coming to the webinar today, you three. I know everybody out there in webinar land. And a big thank you to our panellists, Ros, Dawn and Rhonda. There were a lot of questions here that are fantastic, and we'll try and get back to you around them. And they are spot on. And so I think the people out there listening are onto the money. So you can download the Working Together book for free on the Kids Research Institute website, and very soon it will be available for download on our own website at Transforming Indigenous Mental Health and Wellbeing. We will drop you all an email to notify you when this is available. We will share the recording from today's event along with the slides and relevant links to everyone who registered. And don't forget, you can follow us at Transforming Indigenous Mental Health and Wellbeing on social media. There's a bit happening there. So next week on Friday, the 21st of February, we have another webinar, this one on social and emotional wellbeing, featuring two other authors from the Working Together book, Associate Professor Graham G. and Dr. Clinton Schultz, who will be joined by Madison O'Grady-Lee, PhD student and 2025 New South Wales Young Australian of the Year recipient. We will send registration details to all attendees so you can sign up if you are interested in attending, or you can scan the QR code on your screen. And so I guess, once again, thank you very, very much for our panel, and to Ainsley and Navid for the behind-the-scenes stuff. It's been excellent. We always never seem to have enough time, but there are fantastic questions for you. So the questions are encouraging in that there's work to be done by lots more people. Now, our time might be coming to an end. Never comes to an end, but certainly we'd love to thank our panel, and we thank you very much for taking time out to talk about the book. And yeah, we thank everyone for joining us, and with that, I guess we're due to shut off now. Yep. So thank you very much. Yeah, sorry we couldn't get through all the questions, but they're fantastic questions. So we will endeavour to get back to you about them. So look forward to you joining us on our next one. So thank you very much.
Thanks, Michael.
Once again, thank you to the panel.
Thanks, Michael. Thank you, everyone.
Thank you, Rhonda.
Thank you. Thanks, everyone.
All right.